Our next case study deals with medication reconciliation. I believe that in a previous unit I mentioned that medication reconciliation was one of the most difficult processes to automate, and it certainly is one of the most error-prone processes. In this case study, though, we're going to look across multiple different entities. So this time our patient is again on Medicare, relatively high risk with a business background in healthcare, has a primary care provider and several specialists, and presents to the emergency department midday with a severe respiratory problem and provides the RN a paper list of all medications he is taking. He knows what he's doing. As he is seen in the emergency department, it was determined that the patient needed surgery, but no beds were available in the hospital on any of the applicable nursing units, so he was kept in the ED overnight. His blood pressure medicine, however, had not been supplied to him during the day or evening. The patient had the surgery in the morning and was admitted to a bed by noon. The nurse on the unit completes the assessment and asks about medications being taken, and is told the medication list was supplied to the emergency department. But the nurse didn't have this list, and so the patient, who is drowsy from surgery, recites the list to the best of his ability. During the hospital stay, the hospitalist is in charge of this patient. The hospitalist orders medications, including the blood pressure medication. The patient's primary care provider and pulmonologist visit the patient daily. 5 days later, the hospital pharmacist, who has the medication list from the nurse but not from the patient's original list, visits the patient to confirm a dosage for one of the medications. 5 days later. On the 6th day, the hospitalist and pulmonologist agree to discharge the patient. The hospitalist prescribes medication to be taken through a nebulizer at home. The nebulizer and its medications must be supplied by a durable medical equipment supplier, and so the durable medical equipment pharmacy charges the patient over $700 for the nebulizer medication, which the patient later determines is fully covered by Medicare drug plan except for a $7 copay. But apparently the prescription from the hospitalist did not contain the correct diagnosis code, so the claim was denied. After taking the medication via the nebulizer for a few days, the patient's pulmonologist tells the patient to stop taking the meds. But meds continue to be sent to the patient from the DME pharmacy, which requires an order to discontinue from the ordering physician, the hospitalist. The patient calls the hospital, but the hospitalist has left his employment at the hospital. The patient then calls his primary care physician, the pulmonologist, and ultimately the State Medical Society to see if they know the hospitalist's whereabouts, and they do not. Finally, the patient calls every physician with the same or similar name in a 50-mile radius of his home and finds a hospitalist who promises to call the DME pharmacy fully 1 month after discharge and with many vials of unused and unreturnable meds, valued at $700 each, although the patient has now gotten the prescription coded correctly and is paying only the $7 copay. So our questions for this case study might include, again, what process mapping tool might best illustrate this case study? What are all the breakdowns in communication? Well, there's so many, maybe I should ask what isn't a breakdown, but let's look at all the breakdowns. Who is doing the most to coordinate communications? What are the 1 or 2 things that could most improve the workflow in this process? What is one reason for cost of healthcare being so high in the U.S.? And did the patient receive the best possible care? Again, I'll pause for you to think about the answers. Well, let's look at some of the potential answers to our questions. What process mapping tool might best illustrate this case study? I've actually mapped this process for the patient and successfully used the swim lane chart because of the many different handoffs involved. Again, though, many cases this is personal preference. What are the breakdowns in communication? I've listed 5 major ones. The ED nurse and the patient's ED record, potentially the ED physician and the ED nurse or patient's ED record. So lots of issues with that medication list and getting it into the record or getting from a record. The patient's ED record and the hospital record. Obviously, they're not talking to one another. The hospital record and the hospital pharmacist. Did the hospital pharmacist look at the hospital record? We could probably add there the patient's list, but that's not to be found. The hospital record and the hospitalist with respect especially to the diagnosis code on the order for the nebulizer medications. And the hospitalist and the hospital regarding the whereabouts of their former employee who still has responsibility towards some of these patients. You may have thought of even others. Who is doing the most to coordinate communications? Well, it seems obvious to me it's the patient. What are the 1 or 2 things that could most improve the workflow in this process? I've thought of at least a couple. The personal health record for a patient that is kept current by all who write and discontinue medications. This patient doesn't have a personal health record because his primary care provider's clinic and hospital do not support a personal health record associated with the electronic health record. A fully automated medication reconciliation system between the primary care provider, the emergency department, and the hospital at a minimum. And again, these are very few and far between, and even when they exist, don't do so well. What is one reason for cost of healthcare so high in the U.S.? Well, clearly this illustrates a lot of waste. And finally, did the patient receive the best possible care? In general, he believed yes, and I don't really see anything in the case study, with the stark exception being the inattention to continuance of needed meds the first night in the ED, where the blood pressure medicine was not given to him. But the rest of the issues seem to be primarily annoyances, waste, and so forth. But in general, there isn't evidence of a bad care with respect to this medication reconciliation process, which is a good thing because in many cases the result is bad.